research study here was a systematic review interested at looking at the stigma-reducing interventions that were out there for lung cancer and for chronic obstructive pulmonary disease, or COPD, because we know that stigma is an issue that can often be faced by people affected by these conditions. This stigma is deeply rooted in the links with smoking behaviours, which has over time perpetuated negative attitudes and misconceptions about those affected by these conditions. And so for patients with these conditions, we know that stigma is linked to poorer psychosocial outcomes, for example, distress and isolation. It can delay help seeking for health issues and make patients concerned that their quality of care will be impacted. We also know that research evidence suggests that lung cancer and COPD-related stigma may actually be increasing, particularly as denormalization strategies, for example, those used through smoking restrictions and through mass media campaigns and the like, have been used in tobacco control to discourage smoking. Now, developing stigma-reducing interventions has really been identified as a priority for the field, and the evidence on the efficacy of these sorts of interventions is beginning to accumulate. So we set out to do a systematic review in order to see what was actually out there in the peer-reviewed literature. We wanted to first systematically identify the existing stigma-reducing interventions that had been developed and written up in the literature for lung cancer and COPD, as well as start to synthesize the intervention components and reported efficacy of these interventions. We can start to see how these sorts of interventions are actually working. So the design of our study was a systematic review. We used standard reporting guidelines and the like, guided our review according to the PRISMA, or the preferred reporting items for systematic reviews and meta-analysis standards, and publicly registered our protocol on the Prospero database. We then really focused on terms related to lung cancer, COPD, and stigma, and searched across 4 academic databases up until December 2022. 2 authors from our research team then screened through 425 initial non-duplicate research results for relevant records. And we were really interested in identifying interventions designed to reduce stigma through interventions for lung cancer and COPD. And we considered as eligible studies that described an intervention designed to reduce either internalized or externalized stigma associated with one of these conditions. And then we assessed these studies that were ultimately included using critical appraisal tools, standard appraisal tools of the field. We use the ones developed by JBI as appropriate for the various types of study designs. So in our systematic review, we ended up actually including studies that included a range of different study designs here. They had case report, they had qualitative, they had quasi-experimental, as well as randomized controlled trial designs. In our systematic review, we ultimately identified 10 studies which were describing 9 distinct interventions and included these in our narrative synthesis. Because of the studies having various different types of interventions being designed for different population groups and the like, we ultimately conducted a narrative synthesis to describe what was out there. Now, of these 10 studies, 8 addressed lung cancer stigma specifically. We saw that across the 10 studies, most interventions were designed for individuals who were symptomatic, with their symptoms for either lung cancer or COPD, or the interventions were designed for other high-risk groups, for example, those at elevated risk of developing lung cancer. And most of these interventions had been designed or evaluated through studies conducted in high-income countries. We also saw that most interventions we included yielded a statistically significant reduction in at least one measure of stigma, or a decrease in stigma as reported through qualitative methods. Most of the interventions we included in our review were delivered in either pilot or feasibility studies, and did include comparatively small sample sizes or include comparatively small follow-up durations in their studies, which are the sort of things that would therefore require further evaluation in larger, future, and more definitive studies. We saw that while studies generally showed a low risk of bias in the critical appraisal, there were no quantitative studies identified that included both control groups or multiple pre- and post-intervention assessments, the sorts of things we'd often see in those larger trials. This sort of tells us that there's a need for future evaluations in controlled trials, since it can otherwise be unclear whether the observed results, in terms of stigma reduction, are actually due to the stigma intervention component itself, or perhaps as a result, more generally, of healthcare access. We also categorized the sorts of components that we saw in the interventions there And we summarize these in three main groups. We see that the 10 intervention studies that we identified in the first instance were ones that we considered to be educational interventions. These were ones that typically provided information or instruction or perhaps reference material to individuals affected by the two conditions, or they might have guided behavior change, often via group programs. And as a result, we considered these to be behavioral interventions. Or finally, there were others that we considered to be psychosocial interventions. These were the ones that often provided formal psychotherapeutic intervention, such as that to improve mood, coping skills, and thought patterns. Now, across these interventions, most were delivered with people either with these conditions of interest or those at higher risk of developing the conditions of interest. But one intervention was also directed at oncology care providers, and one targeted family members or supporters, in addition to individuals at higher risk of diagnosis themselves. The results of this review really tell us that there is currently quite a limited evidence base for stigma-reducing interventions in this context. However, the emerging evidence base that we included in this review does show that stigma-reducing interventions can be effective for actually reducing stigma amongst patients diagnosed with lung cancer or COPD, or for people at higher risk of developing these conditions, as well as clinical staff. Now, from the 10 studies that we ultimately included in this review, most interventions identified did yield a statistically significant reduction, at least one measure of lung cancer or COPD-related stigma, or that decrease in stigma as reported through qualitative methods. Now, interestingly, similar effects were also reported for remote and digital intervention delivery compared to more traditional in-person and face-to-face modes, which also does suggest some promise in increasing accessibility for people with comorbidities or loss of function related to their respiratory disease. Further, most interventions that we identified in this review were aimed at reducing feelings of self-blame and shame, or implementing strategies to deal with stigma if it arises in interpersonal interactions. Moving beyond this study, we also need to recognize that stigma can not only be addressed at the individual or the clinical level. So the results we identified in the peer-reviewed academic literature typically focus their intervention at the individual or the clinical level. We didn't identify interventions that were implemented at the more broader community or policy level response. We know that to reduce stigma more broadly can require changes in societal attitudes. And in this context specifically, an understanding of the role that the tobacco industry plays in continuing to sell a toxic and addictive product might be the sort of thing that informs future stigma-reducing interventions. The results of our review also highlight that we need to further develop and further evaluate stigma-reducing interventions for lung cancer and for COPD, and that we need to do this in diverse socio-cultural contexts, and importantly, in partnership with those affected by these smoking-related diseases.